Dr. Andrew McPhee from Australia, Adelaide, is a Principal Research Fellow at the South Australian Health and Medical Research Institute in Adelaide. He works together with Maria Makrides, who was a guest in many Nestle Nutrition workshops. Dr. McPhee is involved in many randomized controlled clinical trials on the impact of DHA supplementation on pregnancy outcomes. And these are long-term studies, and they give us the final answer what DHA can do for us. His lecture title is LC Pufas in Preterm Infants.
Hi. The role of LC Pufas fats in perinatal nutrition is a major focus of our research group at SAMRI. As a neonatologist, my interest in this issue is also keen, given my involvement with preterm and very preterm infants. The LC Pufas, these are EPA, eicosapentaenoic acid, and DHA, docosahexaenoic acid, in the N3 series, and arachidonic acid, AA, in the N6 series, have important roles to play in tissue development, in organogenesis, and in function, and many, many functions. So they have important roles to play in the central nervous system, particularly with vision. They're involved in immune modulation, and they have important pro-inflammatory processes, but also processes via which inflammation is resolved. The effect of the LC Pufas are mediated by molecules called oxalipins. These produce a whole range of families of molecules, such as the prostaglandins, the leukotrienes, resolvins, protectins, maresmins, and so on. If a deficiency of LC Pufas did occur, then correcting those deficiencies in the preterm infant particularly has the potential perhaps to improve neurodevelopment, to improve vision, to modulate the immune system, and perhaps even to favourably modify some of the inflammatory morbidities that are seen in the newborn infant, particularly the preterm infant. Now, for the purposes of this talk, I'm going to start from around 2000 or so, by which time it had been decided that term and preterm formula should be supplemented with DHA to about 0.3 of total fat. This is around the average of total fat found in breast milk. At 150 to 160 mils per kilo per day, this would equate to an intake of around just above 15 milligram per kilogram per day. The studies behind that involved the sentinel observations of Martin Uringer and her team regarding the essential nature of omega-3 fats, comparative studies between breastfed babies who were getting DHA from the breast milk, and at the time, formula-fed babies who had no source of DHA. So looking at levels in red cells, looking at differences in DQ scores, looking at tissue accumulation of DHA, and finally studies that looked at supplementation showing benefit in both development and vision. These were the facts, if you like, behind the decision to supplement with DHA. But what about the preterm infant? If we look at the preterm infant growing in utero, we know that the fetal accretion rate of DHA is about 45 milligram per kilogram per day. We know that the intake at 150 to 160 milligram per day, be it breast milk or formula, is going to be about 15 to 20 milligram per day, which is less than half the accretion rate, even if it was all absorbed. We know that endogenous production of DHA is limited. And for this reason, preterm babies, especially the very preterm babies, are really set up for DHA and, in fact, AA deficiency. So preterm babies have low levels of DHA at birth because DHA levels in fetal plasma rise through the third trimester, and after birth, their low intake leads to a further decrease in plasma DHA and red cell DHA levels. So what about adding AA and DHA to babies? The first study that really looked at that was the Norwegian study from Henriksen. I apologise for the spelling error there. This study looked at babies less than 1,500 grams, and they were breastfed babies, and their breast milk was supplemented with DHA at 32 milligrams and arachidonic acid at 31 milligrams. This was started at the end of the first week and continued until discharge. Babies in the supplemented group had higher problem-solving scores on ages and stages at 6 months and better recognition memory on visual testing at 6 months. A subset of this cohort, about 70% of them, were followed through in subsequent studies. So at 20 months of age, the supplemented group had better attention. But by 8 years of age, no difference in development could be detected. And at the same time, MRI-based studies showed no difference in brain macrostructure. We were very interested in the idea of supplementing with DHA with a pilot study that showed significant benefits with vision. In our study, we decided to leverage off the fact that breast milk DHA content is a direct reflection of maternal DHA intake. So if you wanted to raise DHA in breast milk up from the average of about 0.3, you simply have to supplement mother with enough DHA. So in addition to dosing studies that have shown this, the same thing applies to milk around the world. The DHA content of milks is determined by the mother's dietary intake of DHA. Interestingly, arachidonic acid content of breast milk is fixed at about 0.5% and is independent of maternal diet. So in a way, the DHA variation in breast milk gives us a natural variation with which to test differences in DHA intake. So this formed the basis of our Dino Trial. This was a large randomized controlled trial, which was designed with a primary outcome of neurodevelopment at 18 months corrected age. As I mentioned earlier, a preliminary subgroup of this study were involved in detailed visual assessment studies. So the trial involved babies less than 33 weeks, about 650 of them. High dose group the higher dose group got increased amounts of DHA by taking breast milk with mothers supplemented with DHA. And if there wasn't enough breast milk, then they were provided with formula with 1% DHA. The standard DHA group, the mothers were supplemented with soy, and they had access to a formula with 0.3% DHA. So what did the study show? Remember, the primary outcome was DQ, as determined by the Bailey's 2 at 18 months corrected age. And these results are all corrected for gestational age, sex, maternal education, and birth order. So overall, higher intake of DHA intake was associated with a modest increase in DQ, which did not reach clinical significance. However, in girls consuming high-dose DHA, there was a significant increase in their DQ of 4.5 points. And in addition, less girls consuming a high-dose DHA had DQs less than 70 or less than 85. In babies weighing less than 1,250 grams, there was also a tendency to a higher DQ, but again, this did not reach significance. However, in this group, higher DHA intake was associated with a reduced incidence of DQ less than 85. With respect to secondary analysis, Visual acuity was better at 4 months of A with high-dose DHA, but we saw no effect on growth, ROP, NEC, IVH, or sepsis. But unexpectedly, we saw a trend to a lower rate of BPD in the overall group and a significant reduction in the incidence of BPD in the group less than 1,250 grams. Now, this was exciting. It seemed to indicate that high-dose DHA produced a developmental benefit, particularly in the smaller babies, and it may actually reduce the incidence of BPD, both of which outcomes would be clinically significant and of value. For this reason, we decided to design a study to more sensitively look at these issues, and in so doing, we had another look at the Dino study and realised that there were some issues related to delivering DHA in breast milk. The first issue is that there's considerable biological variability in the amount of DHA you see in breast milk with maternal supplementation. And this ranged from problems such as difficulties with the mothers taking the capsules required to increase DHA, but even in those mothers who are fully compliant, we still saw quite a lot of biological noise in the levels achieved. The other issue related to the use of breast milk to deliver DHA is obviously the fact that the baby is only going to get the full intended dose when they're on full feeds. If we're thinking about the extremely low birth weight or low gestational age group, then we're well aware of the fact that that may not occur for some time. Therefore, for our new study, we decided that we would develop an oral supplement that we could give from the onset of enteral feeding. So in conjunction with industry, we developed a microencapsulated aqueous emulsion of DHA and a control emulsion involving soy oil. And as you can see here, increasing doses of DHA, this is a pilot study, gave increasing levels of DHA. And we decided on the basis of this pilot study that we'd aim for about 60 milligram per kilogram per day in order to prevent the initial drop that you see by 7 days and to achieve an increase in the level of DHA that matches what happens in utero. You can also see on this slide that arachidonic acid levels decrease to about 10 to 15% of their baseline levels. So this study was the NNiw study. It's a large RCT. It involved 13 centres in Australia, New Zealand, and a single centre in Singapore. It involved babies less than 29 weeks. And as you can see, there are 1,273 babies in this study, so a big study. The intervention was 60 milligram per kilogram per day of DHA. The control was a soy emulsion with no DHA. And the outcome of interest for the design of this study was BPD, as defined by the physiological definition from the NICHD. Obviously, we're very interested in looking at the neurodevelopment of these babies, but this study was developed to look at BPD. Now, an important add-on to this study was that we decided to make use of technology that had been recently developed by Bob Gibson and Leo Gurr in our laboratories. This is the Pufas coat dry blood spot. This, if you like, is a Guthrie card for lipids. It allows you to collect, stabilise and store a blood sample for later analysis for fatty acids, for long-chain polyunsaturated fatty acids, and for quite an extensive array of oxylipins. So we have samples of blood from each of the 1,273 babies in the NNiw study at baseline and at 36 weeks gestation, which is when the intervention ceased. So what did we see? Well, as I'm sure everyone knows, somewhat unexpectedly and a little unhappily, we found that high DHA intake was associated with an increased rather than decreased rate of BPD, with this increase of about 5 and a bit % being significant. This is clearly not what we were expecting. It's clearly pretty tight with such a large study group. And so, like all good results, once they're there, they're there. You can't really forget about them. With respect to other problems of preterm neonates, we saw no signal of an effect with respect to ROP, IVH, sepsis, NEC, or length of stay. At around the time that the Dino Trial was being conducted and towards its later stages, a Canadian team led by Isabelle Mark were conducting a parallel study using DHA supplementation via the mother and looking at bronchopulmonary dysplasia as an outcome. In this study, mothers took 1,200 milligrams of DHA compared with the 800 milligrams in Dino, with the placebo in this study involving a blend of corn and soy oil. Again, the babies of interest were those less than 29 weeks, and the original design aimed for 400 babies in each group. Because of the results of the Dino Trial, and based on a interim analysis, the results of Moby Dick, the trial was terminated at 60% enrolment. What did they find? Again, they found that high-dose DHA intake was associated with an increase in the incidence of BPD. With respect to other outcomes, again, sepsis, NEC, and ROP, there was no suggestion of involvement or effect. There was a significant increase in the incidence of NEC in the control group, or a reduction of the incidence in NEC in the, sorry, not NEC, I'm talking about intraventricular hemorrhage, severe intraventricular hemorrhage. You can see there a higher incidence in the control group and a reduced incidence in the DHA group. I think this is unlikely to be a causal relationship because IVH is really a problem that's declared itself by day 3 to 4. And yet the intervention in this study didn't start until about that time. And of course, full feeding, which would have been required to get the full dose, would have taken another week or so. So I don't think this is likely to be causal. I think if you do a quick meta-analysis with the data from the Dino trial, you find that the IVH sort of falls out as something related to DHA. So I guess the question is, or the observation is, that high-dose DHA seems to be associated with an increased rate of BPD. And obviously the question is, well, why is that so? I think some clue to that comes from this study by Camelia Martin and her team in Boston. This study is a preclinical study. It uses a mouse hyperoxia model of BPD. And as you can see in the upper panels there, the mouse raised in room air, the mouse exposed to a period of hyperoxia. You can see this quite distorted lung on the upper right with reduced alveolar numbers and marked thickening of the septal walls. Remember that that thickening is the barrier over which gas exchange occurs. If you take that model and add resolvin D1, now resolvin D1 is a metabolite of DHA, you can see that there is marked resolution or reduction in the septal thickness. While if you take the model and add lipoxin A4, and lipoxin A4 is an arachidonic acid oxylipin, you can see that there's an improvement in the quality of alveolarization. And in the bottom right there, if you add both, you end up with a reasonably respectable looking lung. Now, I guess with this information and knowing the results of Dino and Moby Dick, it could be argued that high-dose DHA reduced access or displaced arachidonic acid, such as to inhibit the production of lipoxygenase 4. Now that's an interesting idea. I think that we do have the oxalipin profiles of all the babies in NNiw, and we are going to be able to explore this issue at some stage. But I think it just raises the question about possible importance of arachidonic acid in this situation. So just to digress a moment, because remember that one of the other things that Dino showed was neurodevelopmental improvements. We followed that cohort along out till age 7, doing a number of studies along the way in subgroups. And at year 7, we followed 92% of the original cohort. And as you can see, we saw no benefit with respect to language at 26 months, no difference with respect to behaviour at 3 to 5 years, nothing with respect to visual processing at 7 years. And at 7 years, with a very extensive battery of testing, we found no benefits in IQ, attention, executive function, behaviour, educational progress, and no effect by sex or birth weight, as was suggested in Dino. The only thing we did find was that girls had poorer executive functions as reported by parents, but not as determined by objective testing. We're not sure of the significance of that observation, but it holds true. The follow-up of the NNiw group at 5 years is recently completed, and I understand that the Moby-Dick developmental assessment at 2 years is also recently completed. And I imagine that we'll see the results of those testings towards the end of this year. So what other studies have looked at high-dose DHA? Mexican studies from Mariela Banabe Garcia and her team looked at an intervention of high-dose DHA, 75 milligram per kilogram per day, given for only 14 days from the onset of feeding. And this is in babies between 1,000 and 1,500 grams, so a somewhat larger group of babies than the very preterm babies in NNiw and Moby-Dick. What they showed in their study in 2019 was a reduction in grade 3 ROP. However, they didn't see a reduction in the overall incidence of ROP, and there was no difference in the need to intervene between the two groups, which rather raises questions about the clinical relevance of the finding. In a more recent publication, in a larger group, but with the same intervention, they reported a reduction in the incidence of NEC. Now, it's difficult to reconcile these with results with the results of Dino and NNiw and Moby-Dick, where we saw no evidence or signal of an impact on either of these outcomes. Finally, and somewhat more excitedly, I think a recent study published in February of this year looked at the effect of enteral LC-Pufas supplement involving both DHA and arachidonic acid on severe retinopathy of prematurity. This is a Swedish study from Hellstrom et al. It has a reasonable basic science support in that we know that resolvin D1 inhibits pathological retinal neovascularization in a mouse model, and neovascularization is the fundamental problem underlying ROP. We know that retinal vascular endothelium has high arachidonic acid content, much higher than elsewhere in the central nervous system. And as shown by this team, low arachidonic acid levels are associated with an increased risk of ROP. So the study involved 206 babies less than 28 weeks. The intervention arm received arachidonic acid at 100 milligrams and DHA at 50 milligram per kilogram per day from day 3 until term. The control group actually received no supplement at all, so technically the study wasn't totally blinded. The primary outcome was severe ROP, determined as stage 3 ROP and/or zone 1 ROP. And as the clinicians will know, this is potentially blinding eye disease. What they showed was a significant reduction, both clinically and statistically, a 50% reduction in the incidence of severe ROP. They found no difference in death, BPD, IVH, NEC, sepsis, or serious adverse events, arguing for safety. The benefits of the intervention were pretty much confined to babies less than 27 weeks. In fact, I only saw one baby in the 27-week cohort who developed severe ROP. But within the 27-week group, there was a suggestion of increased morbidity related to intervention. And in particular, there was a suggestion of an increase in the incidence of BPD, though, as you can see there, the numbers are very small. Now, this is clearly an important study. I think all the clinicians would agree that reduction in the incidence of potentially blinding eye disease is significant. And if it can be achieved by dietary intervention in a very small group of babies, then that sounds fairly promising. So in summary, if we were to consider the evidence to date regarding high-dose DHA and/or arachidonic acid on preterm outcomes, for BPD, we'd have to say that high-dose DHA appears to be related to possible harm. With high-dose DHA and arachidonic acid, I think it's unclear. Clearly, the combined DHA and arachidonic acid intervention in the Megadonna Mega study, that's the Swedish study we just spoke of, that needs to be validated with a bigger study, which would serve to confirm the primary observation, but it would also serve to address issues of possible harm. With respect to ROP, no signal with respect to high-dose DHA, except for the small Mexican study. And with respect to high-dose DHA and arachidonic acid, you'd have to say that that looks promising, but needs further study, needs to be consolidated with a big randomized controlled trial. Other outcomes, high DHA, pretty certain no effect. High-dose DHA and arachidonic acid, we really don't know because we really don't have a big enough study to address that question. Finally, with respect to developmental outcome, I think the results of the Hendrickson study and the results of the results of Dino clearly suggest short-term benefits, but the longer-term impacts of these interventions, again, is not quite clear at this point in time. So that, in my opinion, is the current state of the art. I haven't talked about intravenous lipids because there just wasn't enough time. But I think that the likelihood that they have a significant impact is small. So in closing, much of the material I mentioned today and all the material from our unit reflects the energies of our team. Key players of whom are Maria Makrides, who's the lipid biochemist, Carmel Collins, who ran the Nero trial, Tom Sullivan, who's our statistician, obviously the team there, plus our huge team in our trials network, and of course the babies and their parents, the babies for being involved and the parents for giving up so much of their time and energies to facilitate our follow-up programs. Thank you very much.
Professor Hans von Gaudewer, he's the division chair of Emma Children's Hospital at the University of Amsterdam. He's professor of pediatrics. He's a member of many international societies, served on many international councils, among them ESPGHAN. He's also the founder and director of the Dutch donor milk bank. His lectures on the potential role on nutrition in moderating the long-term consequences of early life stress.
I would have loved to be in China. I really like China. I've been there about 40 or 50 times, but now I'm sitting here in Amsterdam. But will do my best and discuss with you the potential role of nutrition in modulating the long-term consequences of early life stress. And I have prepared this talk together with some wonderful people like Hanna Juncker here, Britt van Keulen, Martijn Vinke, all from the Emma Children's Hospital and the Free University in the University of Amsterdam, Anniko Korosi from the University of Amsterdam as well, and Suzanne de Roy, who is also from Amsterdam UMC. And we have nothing to disclose in relationship to this work. So I'm going to talk about early life factors and how they determine the outcome and what we can do to improve the outcome. And it's good to know that both nutrition and stress have an effect on later neurodevelopmental disorders, on mood and on cognition of the offspring. And the effects are already there during pregnancy, where nutrition and stress play a role in altering the maternal biology, like metabolic and immune and inflammatory and endocrine function that all have an effect on the fetus in the womb. And if the fetus is born, then of course there is also an effect of infant feeding and later on of the diet of the child, of the physical activity, of postnatal stress exposure, maternal parenting behavior, or the postpartum stress, or the mood state of the mother. So all these factors have an effect on neurodevelopmental disorders, mood and cognition of the child in later life. What do we know? Because this is just a cartoon showing what is happening. What do we really know of these mechanisms? Well, we have some observational data. These are observational data from Chile, more than 50 years ago, where they looked at brain weight and brain protein, DNA, and RNA content of infants that died in accidents or of infants that died after severe malnutrition and probably also severe stress. And here on the left upper panel, you see the brain weight, where you have the dots that are the normal Chilean children, and the triangles here are the ones that had who died from severe malnutrition during the first year of life. And you can easily see that the weight is reduced in those infants that suffered severe malnutrition. But not only the brain weight, also the brain protein here, or the brain RNA, or the brain DNA. And actually, if you look at the pattern, you can see it's almost identical of those who died from severe malnutrition, suggesting that the reduction in DNA was also accompanied by a reduction in weight, which suggests that there is just reduced cellularity in those brains of those infants. This is another study from 20 years or so ago from brain autopsy in Mexico from infants less than 2 years of age, where they counted the dendritic spines from cortical neurons. And here you can see 7 normal children, and here 13 data from 13 infants who died of severe malnutrition. And you can see that the average length of the apical dendrites was reduced in those who were suffering from severe malnutrition, as was the average numbers of spines, both indicating structural changes in the brains of malnourished children. Then, as we are in China now, or we should have been in China now, I compared 2 famines, one from my own country. The Dutch famine was that took place in 1945 during the end of the Second World War, where individuals were exposed to a very severe protein energy malnutrition diet with only 400 kcal per day, and also the Chinese famine, which was around 1960, so 80 years ago now. When one looked for an association between the famine that occurred either in early childhood or during gestation and looking at cognitive function at 19 years of the adolescents or the young adults, there was no effect. And also, when you look grossly to cognitive function, there was at 60 years also no effect. But in the Dutch family, when one looked more closely to those who were grown up to 60 years, they found a lower selective attention, which is indicative of the prefrontal function and indicative of early cognitive aging. And exactly that was found in the offspring of the ones who were born or raised during the Chinese famine. Here you see the results from China. Here are a group of now around 50, 55, around 60 years of age of non-exposed people. Here in the black bars, those are at present, at the time of the study, they had a high nutrient consumption pattern and a low nutrient consumption pattern in the open bars. And on the y-axis, one shows the prevalence of global cognitive decline. And you can easily see that when they were non-exposed, it's around 10 to 15%. Also, when they were exposed during the late childhood, it was also around 10%. But during fetal life or early childhood exposure or mid-childhood exposure, you can see it increases up to around 20%. So a clear effect of cognitive decline when you were exposed to the famine and the stress accompanying the famine in early childhood, early life. So adversity early in life, like stress or malnutrition or poor growth, is associated with a negative impact on brain development, on behavior, but also on cognition. What are the possible mechanisms? Well, then it's important to understand how the brain develops in early life. You have in the first trimester neuronal proliferation, the second trimester neuronal migration starts, synaptogenesis starts, apoptosis starts, and myelinization starts at the third trimester and continues, of course, during the early few years of life. Importantly, total brain volume triples during the third trimester. The number of neurons peaks at 28 weeks of gestation, and at 34 weeks around here, 40,000 synapses are formed every second. So it's important to identify at what time an insult is taking place because it can have differential effects on the brain. So perinatal malnutrition, depending on the timing of the insult, can have an effect on cell proliferation, on migration, on the fate. It can have an effect on the function of the neurons, on neurochemistry, redox status, on connectivity. It can have an effect on glial function, on the gliosis, on the myelinization, microglial dysfunction. And all these factors can have differential effects on physical development, on neurological deficits, on impaired learning and memory, and on socio-emotional dysfunction. So what are those mechanisms? How can it exert its effect? Well, by far the most important modulation factor is the hypothalamic pituitary adrenal axis, the HPA axis, but also oxidative stress, epigenetic factors, inflammation, and just the regular deficits of essential nutrients may play a very important role. Just to go back to your textbook from your studies, the hypothalamic pituitary adrenal axis and stress. How does that work? Well, you have the hypothalamus that releases CRH, the corticotropin releasing hormones that stimulates the anterior pituitary gland that on its turn produces adrenocorticotropic hormone, ACTH, that stimulates the adrenal cortex that on its turn produces cortisol and corticosterones. And those cortisol has a negative feedback on hypothalamuses, reducing the CRH release, or has also a negative feedback on the anterior pituitary and there's a regulation of the ACTH levels. So if you look at animal experiments, if you stress them, so the pregnant mothers of rodents, here mice, and you look at the male offspring in this study of Abe in 2007, they found that when those mothers are during pregnancy are stressed, the offspring at about a week of age have higher basal corticosteroid. So this HPA axis is being stimulated. And then when you're looking at, for instance, mood states of those offspring of those young mice, they did a test which is called the forced swim test, which is a sign of depression of the mood. And what they do is they throw those mice into the water and they look how long it takes before they start swimming. And if they're not stressed, the control, it takes about 30 seconds. So they're lying in the water and say, ooh, now we need to swim, otherwise I drown, and that takes about half a minute. If they're stressed, if the mothers are stressed, and that has an effect on the offspring, it takes them more than a minute before they start swimming. Another mechanism is through oxidative stress. One usually thinks of oxidative stress that it has a negative effect. It's also in those creams that prevent aging of your skin. So it has a negative annotation, oxidative stress. But you really need some oxidative stress because it's important for proliferation and differentiation of cells. Only when it's very high, it induces apoptosis and necrosis. So low amounts of oxidative stress is good. High amounts of oxidative stress is not good. One way to induce high levels of oxidative stress is to add fluoride to the drinking water. So here, this is a test again in rodents where they provided the dams during gestation and during lactation with 5 or 10 milligrams per liter of fluoride in their drinking water. And then they tested the hippocampus by what is called the step-down inhibitory avoidance test. It's just you put a rodent here, a mice on the plateau, and of course the mice starts wandering around because he's curious. But on the floor, you have a device that gives a shock to the mice whenever they touch the floor. So if they jump off, they get shocked, and of course they jump back. So when you look at normal mice that are not being exposed to fluoride, you see that if you do that for the first time, it takes them about 1 second because they're so curious, they jump off the plateau and then they jump back. But within 1 second, they jump off the plateau. But after 90 minutes, after they've done this the first time, they don't dare to jump off the plateau at the beginning. It takes them about a minute, and then they become so curious that they jump off anyway. But then after 1 day, they remember, and it takes them even longer before they jump off. So then they're smart and they think for 1.5 minutes, but then still they jump off. When they are exposed to fluoride, the mothers of those infants, and they have high levels of oxidative stress during pregnancy, but also during the lactation period, you see they don't remember that well. So instead of remembering for 1 minute that they shouldn't jump off, they only can recall that for 30 seconds, and at the high dose even only for 10 seconds. And 1 day later, 90 seconds, but only the ones that are exposed to high levels of oxidative stress, they can only remember it for 40 or 40 seconds. There's a difference between males and females in that reaction. So that is about the mechanism of oxidative stress that affects the hippocampus function. Then epigenetics. Epigenetics, you all know, probably it has nothing to do with the content of your DNA, but more of the expression of your DNA, how much proteins are being derived from your DNA. And this is an interesting experiment where you have a mother that is not taking care well of their pups, so with low licking and grooming, comparing to a very nice mother that is highly licking their offspring and grooming with them. that has an effect on the glucocorticoid receptor expression. Low licking and grooming, low expression. And as a resultant, you have high corticosteroid levels in the offspring, high anxiety, and on their turn, the female offspring becomes a low licking and grooming mother. Whereas the high licking and grooming mother has a high glucocorticoid receptor expression in the offspring, so therefore low cortisol levels, low anxiety, and on their turn, they become very nice mothers. Then we go to humans again. This is about the mechanism on inflammation. Here they have looking at associations between the exposure of pro-inflammatory cytokines in utero, in humans, and then looking at functional MRIs made at about age of 45. And again, they find a difference in connectivity and in activity of different regions in the brain, depending on low inflammatory cytokine levels or high inflammatory cytokine levels. And there was also an effect on a differential effect on gender. So for instance, high IL-6 in utero decreases the hippocampus activity, but only in females and not in males. So it's all interrelated in this study as well. The HPA axis is a critical junction for immune factors, for steroid hormones, and as a result in the regulation of stress responses. Then the last mechanism that I like to discuss with you is on nutritional deficiencies. And here, for example, is the example given on iron deficiency or anemia. It has an effect on hippocampus IGF signaling. Iron deficiency through the IGF pathway reduced proliferation or cell growth within the hippocampus. And that accounts for many of the early nutrient deficiencies on copper, on iodine, or thyroid hormone deficiency, or on protein energy malnutrition. They all result in hypomyelinization, in abnormal cognitive function. And for instance, copper deficiency induces again iron deficiency, and they both induce a hypothyroid state in the brain. So they're all interrelated again. So are we able to prevent long-term neurological abnormalities associated with perinatal adversity? Yes, I do think we can. We can help in reducing the amount of stress exposed to mothers or infants. For instance, like programs like family integrated care, where we know it reduces stress levels in the mothers, which we hope then will have positive effects on the long term of their infants. One could try and interfere with genetic factors. And I will show you an example later on. One can try to improve the defense mechanisms against increased levels of oxidative stress, like cystathione supplementation or providing human milk instead of cow's milk formula. One can also, of course, be at the source of oxidative stress, like oxygen, and provide less oxygen to infants at vulnerable stages. One can reduce inflammation by preventing infections, also those low grade, like coagulase negative staphylococci infections, which we all know are not, the infants are not dying from it, but it induces the inflammation of those preterm infants. And of course, prevent nutritional deficiencies. So one should know the requirements and provide the nutrition that is needed to those infants. Just some examples. This is on methyl donors prevention. So here we did a study where we, in rodents again, we provided from postnatal day 2 to 9, when the mothers were lactating to the small mice. We gave them a micronutrient supplemented diet with choline, betaine, folic acid, vitamin B6, B12, methionine, zinc, a 1-chem diet, what we called. cm. And here you see the results. At P9, providing the mother with this diet did have an effect on cortisol levels, because if you put stress to the mothers by taking away nesting material, the offspring had higher cortisol levels, but providing early life stress with this diet, cortisol levels were normal again. Then looking at more cognitive outcome, this is at 4 months. In the standard group, early life stress, less object recognition, but when those mice were provided, or the mothers were provided with the specific micronutrient diet, this effect was abolished. There was no effect, interesting, on DNA methylation in the brains of those offspring, on glucocorticoid receptor expression, neurogenesis, or hippocampal volume. Another example on meat requirements, the effects of omega-3 Pufa availability, so polyunsaturated fatty acids. Early stress exposure, again, during the lactation, it changes peripheral and central fatty acid profiles in mouse. Then by increasing the omega-3 ratio to omega-6 ratio, so with a low omega-6 to a higher omega-3 ratio diet, it prevented early stress-induced cognitive impairments like object recognition. In the unsupplemented diet or the regular diet, a clear effect of the ones that were exposed to early life stress, whereas the diet prevented that effect. Morris-Weiss maze probe trial, no effect after anymore. Object location, again, much better after providing a diet with a higher omega-3 Pufa availability. So in conclusion, the effects of perinatal psychosocial stress and malnutrition, both during pregnancy, but also during lactation, so also on probably the effect on the diet, on the milk of the mammal, those effects are context dependent. They are simultaneously influencing one and each other at various physiological and behavioral levels, and should not be considered in isolation. The identification of the interplay of perinatal stress and nutritional factors may provide us with new clinical intervention pathway, and thereby improving infant and maternal health with long-term health benefits for the child. So we require carefully designed animal and human studies to identify the primary nutritional factors, so we can target those effects the best to ameliorate the adverse effects of early life stress on child neurodevelopment. Thank you very much.
Last but not least, Professor Magnus Domelöv, Professor of Pediatrics at Umeå University in Sweden. Professor Domelöv is our Iron Man because he is the expert in neonatal iron metabolism. He has been doing many intervention studies and randomized controlled trials. Most recently, we learned from his group that less iron for term infants is better, but in preterm infants there is a high requirement. He will talk about micronutrient intakes and health outcomes in preterm infants.
Okay, thank you for the introduction, and I would like to thank the organizers to invite me to talk about micronutrient intakes and health outcomes in preterm infants. And what is micronutrients? Well, it's actually all nutrients except the macronutrients, protein, fat, and carbohydrates. So that includes all minerals and vitamins, and also nutrients like LC Pufas, which I will come back to. And it's important to realize that macronutrients can have very drastic health impacts in preterm infants. Here we can see on the left a massive intracerebral hemorrhage due to vitamin K deficiency. And in the middle, you can see here progressive ECG changing by increasing levels of hyperkalemia, which of course is life-threatening. And on the right-hand side, you can see a humeral fracture due to calcium and phosphate deficiency, which is common in preterm. So I will come back to that, and which also can be caused, of course, by vitamin D deficiency. But it's important to realize that micronutrients very often have much more subtle impacts, but which are nevertheless very, very important for preterm infants. And these are effects on growth, on retinopathy or prematurity, and not least on brain development. And we have used iron as a model nutrient to study the effects of micronutrients on brain development. And as you know, iron is essential for several aspects of brain development, such as myelin formation, monoamine synthesis and function, neuronal and glial energy metabolism, and neuronal growth and arborization. And we performed a randomized controlled trial in low birth weight infants. These were 285 otherwise healthy infants with a birth weight between 2,000 and 2,500 grams. 50% of these were preterm. And the intervention was iron drops at 0, 1, or 2 milligrams per kilo per day. So 0 would be the placebo from 6 weeks of age until 6 months. And at 6 months, we observed that the iron supplementation resulted in very much lower incidence of iron deficiency and iron deficiency anemia. You can see here there was virtually no iron deficiency anemia in the 2 milligram group, but it was 10% in the in the placebo group. But what is interesting is not only the effects on these biomarkers, but on the actual health outcomes. So we studied these children at 3 years, and we found that there was quite a clear effect on behavioral problems. The placebo group had almost 13% behavioral problems, while those who received iron supplements, which are the two next bars here, the two striped bars, had less than 3% behavioral problems, which was similar to a control group of children who had normal birth weight, which means no increased risk of iron deficiency. So in this case, we show that iron supplements significantly reduced behavioral problems, illustrating the increased need for iron in low birth weight infants. And this effect remained at 7 years of age when we followed the children. You can see here, and this here, the effect was mostly seen in externalizing behavior. On the other hand, we have to remember that it's important to avoid iron deficiency in order to improve neurodevelopment, but we also have to avoid toxic effect of iron overload. And this is especially important for iron because we have no mechanism for excretion of iron from the body, and it's a highly reactive pro-oxidant. And also iron is an essential nutrient for many pathogens. So it has been described that iron overload can result in increased risk of infections, diarrhea, poor growth, and even poor neurodevelopment, suggested in at least one study. And we have also seen recently, it has been discovered that iron also can give dysbiosis of the gut microbiome. And we showed this in a trial with 72 healthy iron-sufficient non-anemic 6-month-old infants who received iron drops or high iron formula or a low iron formula during 45 days. And we observed that a clear effect of iron on the gut microbiome, most prominently in the iron drops group, which had less lactobacillus and streptococcus and more Clostridium and Bacteroides. So this effect of the microbiome could lie behind some of the adverse effects of iron. Also, it's important to realize that local practice regarding blood sampling, blood transfusions, and EPO treatment, of course, very much influences iron requirements in very low birth weight infants treated in neonatal units. We recommend the use of ferritin, which is a good measure of iron status also in preterm infants. And this is a study done in a center with a quite liberal transfusion practice. And we can see here on the y-axis, we have log values of ferritin. So you can see that some of these ferritin values are really, really high, but we also have some low ones. And we see that it's clearly related to the dose of blood transfusions that the infants received. Now I will skip to sodium. And I think you all know that hypernatremia is very common in very or extremely preterm infants during the first days of life. And we can see here a clear peak of sodium on day 3. And then the average sodium levels go down here, plasma sodium. And after the first week, hyponatremia is actually the more prominent problem in these babies. And this is because poor reabsorption of sodium in renal tubuli causes sodium losses in the urine. So because of this, it's recommended to have a very low sodium intake during the first days. And then after day 4, we recommend a much higher sodium intake of 3 to 7 millimoles per kilogram per day. And this usually or frequently, these babies will require sodium supplements. It's important to realize many people think that these hypernatremia during the first days of life is mostly due to sodium given with parenteral nutrition. But as you can see here in the leftmost bar, actually in this study, only a very small proportion of the sodium given during the first 3 days was from parenteral nutrition, and most was actually from blood products through flush solutions, medications, and saline infusions. So it's very important to remember to minimize those sources of sodium in the first 3 days. And we actually, this is some unpublished data from our group where we investigated the effects of a parenteral nutrition solution without having a special low sodium and potassium concentration during the first 3 days of life. And we can see here when we give 2 millimoles rather than 0.7 millimoles per kilo per day from parenteral nutrition, and also a higher level of potassium, 1.2 versus 0.5, we actually observed no difference in hypernatremia, as shown in the top figure here. And we did observe more hypokalemia with a lower potassium intake, actually here, 76% versus 30%. So these results suggest that there might not be a need for a special low sodium and potassium solution during the first 3 days of life, and that really we should maybe increase the lower limit of the recommended potassium recommendation from 0 to 1 millimole per kilo per day. So now I will skip to phosphate or phosphorus. And early hypophosphatemia is very common in very low birth weight infants during the first week of life. It may be life-threatening, and the risk factors are small for gestational age babies, and especially with a high amino acid supply with inadequate phosphate supply. Hypophosphatemia is usually defined as less than 1.5 millimoles per liter, and severe hypophosphatemia less than 1.0 millimoles per liter. And this is not a phosphate deficiency, it's a shift between fluid compartments. So as seen here, if we give parenteral nutrition with amino acids, these will be transported into the cells and bringing with them into the cells phosphorus and also potassium, and the lower phosphorus in plasma will cause a release of calcium from bone tissue. So these early hypophosphatemia very often is associated with hypokalemia and hypercalcemia, and in many cases also hyperglycemia. So it's important to check for these early hypophosphatemia because it can be severe and it can even be life-threatening. However, the late hypophosphatemia, which is common in very low birth weight infants after 4 weeks of life, is associated with osteopenia and deficiency of both phosphorus and calcium. And so if you have a low phosphate level, you should also check alkaline phosphatase, which is usually increased in these situations, and you should do an X-ray. And importantly, calcium levels are not useful to screen for this osteopenia, because the calcium levels are usually normal or even elevated. The highest risk of osteopenia, even with fractures, is seen in infants or preterms on long-term PN, especially those that have undergone abdominal surgery, and they might also be treated with steroids and diuretics. And treatment and prevention include adequate phosphate and calcium supplements, and of course vitamin D. Now I will mention long-chain polyunsaturated fatty acids. As you know, there are two versions. These the omega-6 fatty acids, exemplified here by arachidonic acid, and the omega-3 series, exemplified here by DHA. And really, humans can produce these from linoleic and alpha-linolenic acid, which are very common in the diet. But we think that preterms especially have an immature delta-6 desaturation activity, and therefore might need extra arachidonic and DHA. LC-Pufas are essential for normal brain and eye development. It has been a lot of research in this area since the 1990s. Most studies have focused on DHA. Some studies have shown a positive effect on visual or cognitive development in term infants. Even though the jury is still out, I would say, on term infants, but in preterms, suggested health benefits have been suggested on brain development and reduced ROP and BPD. LC-Pufas are present in breast milk, but they are highly dependent on the mother's diet. We know that postnatal deficiency of DHA and arachidonic is common in extremely preterm infants. We can see here from a Swedish study that the serum levels of DHA and arachidonic acid drop quite a lot during the first week of life, and this is regardless whether the babies get intravenous lipid emulsions with these fatty acids. So enteral supplementation has been suggested, and this is an Australian study showing that, or the hypothesis in this study was that DHA supplementation would decrease the risk of BPD. However, on the contrary, it was shown that there was a significantly higher risk of BPD in the group supplemented with DHA. So, but it's important to realize in this study they did not use any arachidonic acid, and it might be so that you need to have a balance between these omega-3 and omega-6 fatty acids. So a very recent Swedish study where 101 extremely preterm babies randomized to either a combination of DHA and arachidonic acid or placebo from less than 3 days until term age. And here we showed that the supplemented infants had a 50% reduced risk of ROP, which is very interesting, I would say. And we are now awaiting the result of a similar study underway in Norway, in Oslo, where 120 preterm infants, less than 29 weeks, receive almost exactly the same intervention as in the previous study. The primary outcome here is brain development as assessed by MRI at term age, and the first preliminary results are expected in the fall of 2021. So where can we get advice on recommended intakes of micronutrients? Well, the European guidelines, the ESPGA and ESPEN-ESBR guidelines are from 2018 are available, and they are for children at all ages, including preterms. So this is quite good information for preterms. And what about the enteral? Well, we have these ESPGA guidelines from 2010. But they are actually being revised right now, and this is from an author group meeting in February 2020, right before the pandemic. And this paper will include lots of sections, and several of them will discuss micronutrients. And I would just give some examples of what will come out in these new guidelines. Vitamin D We know there's a huge research interest, but there's a lack of well-performed studies in preterms with clinical outcomes. And bone health is actually the only evidence-based clinical outcome, but there is no clear evidence that higher doses than about 200 to 400 international units per day improves bone health. And the previous dose recommendation was 800 to 1,000 international units per day, not per kilo. Almost all studies performed in infants are performed in infants with weights around 1,500 grams. So very little is done on the smaller preterms. So, and for a 500-gram infants, if you give 1,000 international units per day, that's 2,000 international units per kilogram per day. And the safety of this is really not shown. Possible adverse effects of too high doses of vitamin D include nephrocalcinosis. So the new recommendations, which are evidence-based, are now lower than the previous, and importantly, they are framed per kilogram per day, which is similar to all other nutrients, not just per day, but per kilo per day. So the new recommendation will probably be 400 to 70 international units per kilo per day, up to a max of 1,000 international units per day. And this table shows what the results will be in different weight categories. So you see here for 500 grammers, it would be 200 to 350 international units per day. And for a 1,500 gram baby, it would be 600 to 1,000 international units per day. And the old recommendation was 800 to 1,000. So slightly different vitamin D recommendations. Zinc is another important micronutrient. It's important for growth, immune defense, wound healing. You can see here a picture of the typical rash you can get with a zinc deficiency. We have no toxicity problems like with iron. The traditional fetal accretion calculations are based on preterms in the range of 1,500 to 2,000 grams, but infants with a weight less than 1,500 grams would then theoretically have higher needs. A randomized controlled trial from 2013 suggested a zinc intake of 6.6 milligram per kilo per day compared to 0.9, reduces neck and mortality. Of course, this needs to be confirmed, and this is a very high intake, which is higher than the estimated requirements. A recent Cochrane meta-analysis published this year showed that zinc supplements for preterm infants may decrease mortality and probably improves weight gain and linear growth. This Cochrane analysis included some different notes, including this trial from 2013. So overall, weighing in all this evidence, the new ESPGHAN recommendation is higher than the previous. We now recommend 2 to 3 milligrams per kilogram per day, and the old recommendation was 1.1 to 2 milligrams. Please observe that these recommendations that I just mentioned are not finalized. All recommendations will go through a Delphi procedure requiring 80% consensus. We aim to have these new recommendations published in the end of this year in JPGN. So how do we keep track of all micronutrients? Many clinicians, we know, they feel that the micronutrients, they are bothersome and they are complicated and there are too many of them and everything is very difficult. But I would just have some important points to remember, take home message. What about checking micronutrient status? Well, I would suggest that you remember to check serum phosphate to check for this early and late hypophosphatemia, and also that you check serum ferritin at least before you start giving iron supplements. And then also remember that assessment of vitamin and trace element status is really tricky. It's quite unreliable in infants with ongoing inflammation, and there's a very good review paper published last year from the ESPGHAN Committee on Nutrition on this topic. We do have our guidelines. We know the recommended intakes, and there will be updated guidelines, as I mentioned. But then you really need to have computer support for prescription, and there's some really good software out there. We have developed this software, for example, to show not only the macronutrient intakes, but also the micronutrient intakes. So this is an example, a 25-weeker, 700 grammer, 7 days old. And the prescription here contains mother's own milk and a parenteral nutrition solution. And you see that this combination gives a very good fluid intake, energy intake, protein, amino acid intake, carbohydrate, glucose, and lipids intake. So all the macronutrients and fluid is perfect. But then if you look at the micronutrient intakes, they are not very good at all. A very low sodium intake, low calcium, phosphorus, magnesium, and very low trace elements and vitamins. So here is the same prescription, but it has been added vitamins to the parenteral nutrition solution and also trace elements. It has been added half dose multi-nutrient fortifier to the breast milk, and on top of that some multivitamin drops and some extra calcium and phosphate supplements enterally. So here we see we can achieve a good intake also of the micronutrients. So in conclusion, micronutrient intakes have crucial short and long-term impact on health outcomes in preterm infants. That's a lot of ongoing research. It's a hot topic, and recommendations are available for parenteral and enteral intakes. And please remember to consider macronutrients when prescribing nutrition. So thank you very much for your attention, and I would like to thank all my co-workers and our research funding agencies. Thank you very much.